Well, good morning and welcome everybody, especially our speakers, Dr. Lowell Kleinman and Sharon Iverson. Dr. Lowell, who will speak first, was born in Brooklyn, New York, and he's board certified in family medicine as well as hospice and palliative care. He serves as palliative care medical director for John Muir Health, and he practices palliative care in the ambulatory and hospital settings. He and his wife and 3 children enjoy their time together outdoors and love playing with their dogs. Lowell, welcome.
Thank you. Should I just start speaking then?
Yeah.
Yes.
So I'm originally from the East Coast, and I came out to California in 1993. Only intended on staying a couple of months, and so that was many, many years ago. My background in family medicine, I've been in different settings. I've been in a private setting, in a group. I've been in solo practice. And then most recently back in a group, John Muir Medical Group. And about 10 years ago, I became interested in hospice, really because my family practice patients were entering into hospice scenarios. I was following them, and I took an interest in it. I had never really heard of palliative care, and so became interested in that and became board certified. And so I'm doing clinical work in palliative care, but also some program development work as well. So maybe a little bit about what the modern day definition of palliative care is. And it's a relatively new specialty in the last 20, 25 years and become more popular recently. For those of you in primary care, actually, I'd be really interested to hear if you feel like you've always been practicing palliative care, because my view for family medicine and primary care is that there's so much overlap between what I had always done and what is now being called a specialty. It's just really interesting to think about it in those terms. But the specialty's definition is that we take care of patients who have serious illness, and often these are life-threatening conditions and end-stage illnesses from the things that we all commonly treated. So end-stage heart disease, lung disease, kidney disease, and also we treat a lot of cancers. And our main focus is to develop relationships with our patients and their families so that we can get a deep understanding about what's important to them at this stage of their life and their illness, so that we can best align the future care choices that they're being offered with what's important to them. We also, in addition to getting a lot of extra training and communication around those, getting to know and how to talk to people about prognosis, we do a lot of symptom management. And so all the end stage illnesses that we care of, they all come with various symptoms. And so we have a lot of expertise in symptom management. So that's kind of the big picture of what we do. And I'll just pause there. Any questions about the specialty before I go on to describe what we're doing at John Muir?
If you have a question, you just unmute yourself and ask the question. Does anyone have a question at this point? I think we can go on, Lowell.
Okay.
What's the difference between your specialty and internal medicine?
So there's a tremendous amount of overlap. We have extra training on communication skills and extra training on prognosticating, extra training on symptom management, but there's a huge overlap between palliative care and any of the primary care specialties, whether it's internal medicine or family medicine or geriatrics. The one really important difference, which I think really defines my field more than anything else, is the amount of time that we get to spend with patients. So for example, my initial consults with patients are commonly 90 minutes. And follow-up visits are commonly 60 minutes. And that's so different than primary care now. So when I'm wearing my family medicine hat and I've got my 15-minute, if I'm lucky, 30-minute appointment, there's just not the time to cover the chronic conditions and have the kind of discussions you can have in 90 minutes about what you want with the type of care going forward, and what are your preferences, and what are you worried about, and what are your fears, and what are your worries, and what keeps you up at night about your illness, and what worries your spouse and your family members, and what kind of questions do you have. So one of the big defining features of palliative care is the amount of time we spend with patients. So I think that's truly one of the most advantageous things that we have. So a little bit about the program at John Muir. The palliative care inpatient hospital program has been present for at least 10 years. And I came on board about almost 3 years ago this September to begin the ambulatory, the outpatient program. And so now we have a palliative care clinic that's in 1450 Treat, our John Muir building there. We have an office in Concord, and we are about to open an office in the East County area in Brentwood. So that'll be coming up soon. So that's the locations of our clinic. We also have a home-based program. So prior to COVID, we were going to a lot of people's homes all throughout Contra Costa County, primarily focused around the John Muir area, but we went up to Martinez and Brentwood. So that program is starting up again. We never stopped. We converted the home visits, the house calls, into telephone visits, and for those that could do it, video visits. But that program has been in place for about a little over 2.5 years now. So we have a clinic, and we have a home-based program, and now we have a hospital program. And the makeup of those programs, it's a diverse group of people. And the reason is because when you think about someone's illness and serious illness, the kind of questions they have are typically not just medical questions, right? So they have medical questions, of course, but there's also, I'm having trouble taking care of myself. I'm too short of breath due to my emphysema. I'm very fatigued due to my end-stage renal disease. I can't cook and do the day-to-day chores. I'm having difficulties with finances. So we have social workers in our program. So we have physicians, we have social workers. A lot of illnesses are very spiritual in nature in terms of some of the issues they rise up, and all sorts of questions about, why is this happening to me? And did I do something to deserve this? I don't see any purpose in going on anymore. What, at this stage of life, I've lost my spouse, I'm alone, I don't really want to go through this. So spiritual type issues. And so we have a chaplain. So we have physicians, we have social workers, we have chaplains, and we also have nurses. So the nurses will come to the home and they can spend 2 hours with somebody doing all the things we just spoke about. And then we also have nurse practitioners. So it's a program has a lot of different types of people working in it. And so that we can do a good job for patients, we meet together once a week. And so we used to sit around a table, and now it's by phone or Zoom, and we'll talk about Mrs. Smith, and the physician will give his or her input, and then the chaplain might say something, the social worker might say something. And the benefit of being together is that you get this really full picture of what it's like to have an illness that's a severe illness. So that's some of the descriptions about what we're doing and who's in the program. So I'm going to hit pause again and see if there are any new questions.
I have a question, Lowell. Is this paid? How is this paid for in terms of that? And also the second question is, how do you get into the program? I mean, you normally think, oh, I've got this problem with an itch, so I'll go to a dermatologist. But I don't think about, I have this illness and I want to have palliative care.
Right. So the physician and nurse practitioner services are paid for through traditional health insurance. So if you have Medicare or any other insurance, it pays for that. What insurance doesn't pay for, but it's starting to, are the nurse visits, the social worker visits, and the chaplain visits. And so a health system that's going to offer palliative care can either do this because they've got a foundation arm that can support it, or there's some sort of donation, or a health system more commonly sees that if we are able to have discussions with patients, find out what's important to them at this stage in life, what kind of care do they want, very often we'll hear comments like, I don't want to go to the ER anymore. I don't want to go and spend 5 days in the hospital. It doesn't help me. I feel worse. I end up having to go to a skilled nursing facility for weeks. I'm away from my family. It's not what I want. So if we're able to develop a treatment plan that can help someone stay in their home, then a health system is able to save dollars. And so they use those dollars saved to pay for palliative care programs. So that's how throughout the nation, these programs are typically paid. It's evolving because insurance companies are seeing the same financial situation. And so they are starting to cover palliative care programs as well. In terms of getting into the program, it's either you can self-refer or somebody else, a physician or nurse practitioner, can refer you. And we're starting some programs where really anybody in the health system can refer you. And what we do is we evaluate the chart and we quickly take a look and see, is there a life-threatening or end-of-life kind of illness going on? Is there a significant suffering that we can help? Are there discussions we can have? And then we schedule an appointment.
Thank you.
Lowell, may I ask, it might be helpful for the group to hear the difference between palliative care and hospice care.
Right. So because those two words go hand in hand, it's been a bit of a problem because people will misinterpret palliative care as hospice care. And what that does is it gets in the way. It gets in the way of patients and families having the discussions I just outlined because they're misperceiving it as giving up, as this is the end, as I'm going to go into hospice. So they're connected. Hospice is actually a type of palliative care. There's a lot of overlap in terms of discussions and symptom management. But hospice, as you know, is a Medicare benefit designed for the last 6 months of life. Whereas palliative care, we don't have the criteria of how long do we think someone's going to live. First off, we're not good at that. Nobody really can prognosticate that well. And more importantly, it's not designed to address the last 6 months of life. The stress and burden and the suffering around serious illness often happens way before the last 6 months of life. It can happen years before. And so I have many of my patients that I'm sure are going to be alive for the next 2, 3, 4 years, but they're suffering from late stage COPD, or they're suffering from mid stage dementia. We have a lot of patients whose spouse has dementia and they don't, and they are needing our social worker and nurse support services to help them with the behavioral symptoms that they're seeing, with some of the activities of daily living, the support, the financial issues, in addition to the medical issues. So two of the big differences, one is hospice is the last 6 months of life, whereas palliative care does not have to have a time clock associated with it. And hospice also exclusively focuses on comfort. People aren't treating their illnesses. They're not trying to get a cure or maintain their illness. They may be hoping for that, but they're really focused on comfort. Whereas palliative care, the majority of my patients are actively treating their illnesses. They're going to see their pulmonary doctors. They're going to see their oncologists. They're going to see their neurologists. So they're still very actively trying to treat things, sometimes expecting a cure, often wanting to maintain things. Whereas in hospice, the focus really is comfort. So hospice is a 6-month prognosis with a focus exclusively on comfort. Palliative care, we don't have a prognosis time clock. And our focus is on the stress and burden of illness, whether you're trying to treat for a cure or not.
Thanks, Lowell.
So any other, I'll talk about the future direction, but Cynthia.
Yes, when you're talking about comfort care, what about comfort care for palliative patients who are suffering?
Right, so we, good question. So we absolutely focus on comfort. So majority of my palliative care patients have some sort of pain from their illness or breathlessness from their illness or fatigue or depression. And so I do a lot of work on symptoms.
Question? Okay, I think you can go on. Okay, thank you.
Oh, looks like Michael has a question.
Yeah, I think as I understand the word, palliation means not aiming for a cure. It's putting off all the things we mentioned, discomfort and stuff. And I'm just wondering, when you have someone who has a eventual terminal illness like pancreatic cancer that has a pretty poor prognosis, and someone opts not to do massive chemo or something, do you have regimens to help with that are specific, or is that just a general problem?
So a couple of comments. An important one is that when we meet patients, I don't have a specific agenda. I try very hard not to really enter any biases I have unless I'm asked about what they should do, what they shouldn't do. I have a really good in-depth conversation about who they are as a person and what do they want and what do they know about their illness, what questions they have about their illness. And I try to get to know my patients before I say anything, because a lot of patients, and pancreatic cancer is a really good example. I have a call later today with a patient who was recently diagnosed, and he doesn't want to know how bad it is. He is very focused on a miracle's going to happen, chemotherapy is going to work, and he doesn't want to hear anything other than that. Had I not learned that about him first, I could very well have said something that would have upset him, interfered with our relationship, and gotten in the way. And so I don't want to remove hope from anybody. And the best way to do that is to not have an agenda other than to get to know your patient. Now, having said that, with pancreatic cancer, there are lots of patients who have read about it and completely understand the road ahead, and they want nothing to do with chemotherapy. They believe that chemotherapy is going to rob them of quality of life. They don't want to go to the ER from complications. They don't want to go to the hospital. They don't want to spend time. Really what they're saying is they don't want to medicalize the end of their life. And when I hear that sort of thing, then great, those are my marching orders. So I know that I'm going to be talking to you about how do we get you to go visit your grandkids in this time of COVID? You know, how do we get you to talk about leaving a legacy about who you were as a person to grandkids who are too young to even talk to you yet? What sort of things bring you quality of life? What worries you about your spouse? If you're going to pass away in 3 months, do you want to talk about ways that we can better prepare your spouse? What do you want to do if an emergency happens? If you're at home and you're developing a major complication from your cancer, do you want us to call 911 or do you want another option? Very, very common recently, I've been getting a lot of questions about the End of Life Option Act. So the California law that allows people to take a medication to end their life. And so that's become, for me, I don't have an agenda, but I'll always ask patients, and I'll say something like, you know, there's this new law, it's called the End of Life Option Act. I've learned to bring it up with patients because often they're thinking about it and they won't bring it up if I don't bring it up. So I'm just curious if that's something you ever want to talk about, let me know. That's about the most agenda I ever really get. And I'll tell you, at least 3/4 of my patients want to talk about it.
Wow. Well, that's very interesting. Thank you. We have a speaker from hospice talking about that next Friday.
Okay, so a week from Friday, Susie Crandall will be back talking about the end of life option issue.
Yeah, and so you know, I hope not to offend anybody with discussions about the End of Life Option Act, because people are in different religious and political views of that. For me personally, I'll just let you know, I've been very involved in it. I have probably helped over 50 patients at this point. I've been there for the death, so if anyone has any questions about that sort of thing, I'm happy to answer those as well.
I have a question. In 2016, they passed that law that you could choose your own ending. And I helped a friend die, Kaiser patient, who got 90 secanols, had to be taken apart, mixed with something. Is there a better choice now? And if so, what? And also, the hospice people said they were having trouble finding any doctors who would prescribe whatever pill that it is. Do you prescribe, and what is it you prescribe?
Yes. So the law states you have to have two physicians. One is the attending physician who does the prescribing. The other is the consulting physician who concurs that you have a 6-month or less prognosis, because you do have to have that to qualify for the law. And I don't prescribe Seconal anymore because of what you just described. But the cocktail I use has about 5 different medicines. You take some medicine an hour before, anti-nausea. You take some medicine a half hour before to slow the heart rate down. And the actual medicine that ends life is a mixture of morphine and Valium. And so when taken, the average
All
length
orally? All orally?
Yes. Yeah. And so you have to have the ability to swallow. And so I watch all of my patients swallow a small glass of water to make sure they can do it. You have to have the ability to self-administer it. A spouse can't do it because that's murder. And so we're not allowed to let spouses do it. And typically patients will fall asleep within a minute and typically pass away within 5 minutes, but the average length is, I think it's up to about 45 minutes or thereabouts. If we look at all the thousands of cases, that's the average. But of the patients I've done, probably the average passing away, I'm going to say, is less than 10 minutes.
That is a vast improvement.
Yeah, it is. And also the cost, as soon as the law passed, Seconal, which has been around forever, right, used to be cheap as dirt, became this, multi-$1,000 medicine. And
When
so
my friend asked me to do this, I went immediately to the pharmacy to ask how far in advance I could prepare and what it could be added to, how long, how it should it be kept, did it need to be refrigerated? They didn't know what Seconal was. So I went to another pharmacy, all here in La Miranda, and I got the same response. I asked both of them where they went to pharmacy school, and they'd gone to UOP. The third CVS, I thought, well, it's bigger, had the same response. He didn't know what Seconal was. I said, where did you go, Jordan? So it's now become popular again, I guess, if the prices have gone up.
Well, so you run into different things, different scenarios. Pharmacists have the right to refuse.
Right.
And so, and that's fine. This doesn't have to go down that pathway. And if someone refuses, I use a pharmacy that's actually on the peninsula, and believe it or not, they FedEx the medicine to the house. And so they have expertise in it. They've done thousands of these. They call the patient. They make sure everything is in order. And so that's how I do it. There was another question you would ask. Oh, in terms of finding people to do this. So in our area, there's a physician in Berkeley. His name is Lonnie Shavelson. And so he does quite a few of these. I'm in our area, so we overlap territories. So I don't think it's too hard anymore to find a physician.
Good.
Yeah.
Thank you.
Okay. Any other questions? Go ahead. Lowell, in terms of just to clarify, when we asked about who pays, if it's not covered by Medicare regular insurance, is it like, for instance, in your program, does John Muir have a foundation or something that pays for it, or does the patient pay for it?
So John Muir pays for it, not through its foundation. The health system has decided that this is a worthwhile thing to be doing. And so a patient doesn't get a bill. This is something that John Muir pays for. Other organizations, most organizations, the health systems are paying for this. Rarely a patient pays out of pocket for certain programs, but most of this is paid for through health systems.
Okay, thank you.
Larry? Larry?
Yes, Karen?
Yes, Chris has a question.
How has the Corona-19 virus affected your program?
It's been horrible, really, because we are so relationship based that the idea of talking about something like pancreatic cancer only over a phone, the idea about talking about the End of Life Option Act through a video, for someone like me, it's been a significant issue. But I will say, I'm getting patients the care they need, right? So I have lots of new patients who are in my palliative care practice now. I've actually never met them. I've done video visits and phone visits. I think the human touch is important and key and a really big part of palliative care. But we are in obviously crazy, never before in my lifetime situation. And so we're making do. So I think if you ask patients, you're going to get a better response than what I just said. I think they're finding that they're getting what they need.
Okay,
Thank you.
thank you. Thank you. Okay,
Ask a final question.
Pearl's going to ask a final question. If Lowell, you can stay around, and Sharon's going to give her talk and then answer questions, and then we'll open it up for more questions. Is that okay with you?
So I actually have a meeting, so sorry.
Okay.
I can answer any questions, but I won't be able to stay around. Sorry.
Okay. Well, then let's get any more questions before we move to Sharon.
Okay, and my question is, next speaker is going to talk about advanced directives. And we heard that Hospice of the East Bay will automatically help a patient get the advanced directive done. What do you think about advanced directives?
So I should have mentioned that because that's a large part of what we do also. So really anybody who's taking care of end stage illness, we need to take the responsibility to bring up advanced directives with patients because frequently they won't. There are so many ways to get advanced directives done. I can sit down and do them. Our social worker can do them. You can go online and do them. Hospices can do them. Family medicine, internal medicine. I mean, everybody nowadays has the ability to have an advanced directive discussion. Now, there's forms that get filled out, and I'll tell you that the discussions that happen around those forms getting filled out, they're not always high quality discussions. That pink form, the pulsed form, sometimes it's filled out incorrectly and more often than we like. But often when I have a patient who has that pink form filled out, I still go over that with regards to, does this represent what's important to you, what you want? And a lot of times the form gets altered because they didn't have a really good advanced directive conversation. So I'd say the ability to have the conversations is ubiquitous. The training of the people having the conversations definitely needs to be improved. But still, there are people who do this very commonly, and they do it awesome, and they create great advanced directives. And we have to check in with people frequently because at the early stage of an illness, someone may want CPR, and they may want to be intubated, and they may want certain things that are going to be very different 6 months. So anytime there's a change in condition, I always check in. Does this change your advanced directive thinking in any way?